Your mini session for week 6 of ST 332, Chapter 16, Moving, Handling, and Positioning the Surgical Patient. We've got some learning objectives. List and discuss the principles of safe patient transport and transfer. Demonstrate professional communication skills with families of patients being transported to surgery. We got to look at body mechanics because that's important. You only have one. And discuss common methods of patient transport and lateral moving devices used in the perioperative environment. Now, this is lesson 16.1. Now, patients must be transferred in a lot of different ways, okay? That's going to automatically create risk for us, not just for the patient, but us as healthcare workers as well. And you have to think about the condition of the patient. A lot of times they are not going to be stable. They are not going to have all their strength. So you're going to be carrying extra load at some times. So we use stretchers, we use wheelchairs that can unfortunately slip unexpectedly. But before we do all of that, we have to check the patient. We check their identification band. We ask the patient his or her name. And then we ask the patient, you know what? Why are you here? Do you know what is the procedure that's going to be performed on you? We also have to know the risks, okay? Remember that the patient often is there on the worst day of their life. So we want to protect their dignity at all times, and we are moving with a purpose. And you're going to hear that from the operating room to taking a patient's family back. You're moving with a purpose. Everything is done deliberately. You have one person controlling the movement, you understanding all the equipment that's around you, and you do not abandon your patient, okay? You're going to be with that patient because we want to protect them. And then we go back to identifying that patient's ID. Sometimes you may have to talk with the patient's family, but keep in mind, remember, they will be anxious. They're going to be nervous. Allow them to kind of come with the patient as far as possible. In peds, there's times where we do a parent induction where the parent comes all the way back to the operating room. Their child is placed on the operating room table, and that parent is there until the patient is comfortable, and sometimes even when they are intubated. And then we walk the patient back up to recovery. But you want to make sure that you're reassuring the family of the patient's well-being. You're not giving false promises. You're not saying we're here to save the world, but you're just kind of, being there. You may be there with the surgeon when they're giving updates on the surgery's progress, the patient's condition, right? Sometimes you may be that person right there with the surgeon. Now, there are guidelines of body mechanics, and this chapter lets us know. Now, we are at a high risk for back and other musculoskeletal injuries, okay? Our tasks are unpredictable, which can unfortunately lead to injury. So always have enough help when you're moving a patient. And you see there's a lot of individuals here. Be prepared for possible weight shifts. Maintain the spine in as a neutral position as possible whenever you can. And you do want to avoid twisting your spine, especially when you're lifting or bending. You position your patient or yourself as close to the patient as possible. This is going to greatly reduce spinal load. You're going to keep your feet kind of far apart to give yourself a wide base of support. And let's say you're doing lateral moves, right? Well, you're transferring the patient from one surface to another, so you're not going to bend your knees. The chapter says do not bend your knees. For vertical moves, up or down, do bend your knees. I see that as a question. You also want to avoid awkward positions that reduce your base of support. Again, when possible. I'm going to be transparent. There are times in the operating room where you're going to be in awkward positions holding different instrumentation depending on the surgical procedure. But never try to lift or maneuver the patient while reaching forward away from your center of gravity, because you could actually cause more harm on yourself. You want a strong core. Okay, so you're using your abdominal muscles, your arms, your leg muscles when you're lifting these patients. Your abdominal muscles can support like your trunk much more efficiently than your lower back muscles. You do not want to strain your lower back muscles. There are times when you are standing on your feet. But we do have different types of transfer devices. Of course, we have our gurney, which is our stretcher, wheelchair. Let's say they have a walker, so that would be like a gait device. But we also have lateral transfer devices, air assisted lateral transfer systems. Oftentimes, you'll see a transfer board. We have roller boards, and then we have patient slings as well. Hopefully, you don't find yourself where a patient's going to fall. But if a patient begins to fall, do not try to hold the patient up. You will most likely hurt yourself and the patient. Instead, you want to control the fall and ease the patient to the ground while protecting his or her head. And you kind of see that in the image in figure 18, figure that you see in front of you, where you're just assisting a falling patient. Okay, you're assisting a falling patient in figure 16. Now, we look at the types of emergency situations that occur during transport. Now, the patient may suffer sudden hypotension. They may go into cardiac arrest or seizures, okay? This is going to affect moving of the patient from the bed to the gurney and can cause vascular or fluid shifts that may not manifest symptoms immediately. So you maintain verbal contact. You're going to shout for help and activate whatever alarm that you can find near you. All right, so that was 16.1. In 16.2, we're going to look at guidelines for transporting special patient populations. What do we do in patient positioning? Demonstrate the use of common operating table accessories and positioning devices, because you're going to get a lot of exposure to the operating room bed, and describe how to prevent patient injury during positions, looking at safe positioning, basic positions used in surgical procedures, and safety precautions. We do have a video in this particular section. So, special patient populations. Now, when we look at our infants and our children, we got to make sure the cribs used for transport always have some type of plexiglass cover. Again, you're never going to want to leave these patients alone. Keep the child calm, and then make sure that you're just explaining the situation in a way they will understand. Remember, you're wanting to come to their level. There are risks. We do a lot of bariatric cases. All right, now there are several risks associated with obesity, including, of course, diabetes, heart disease, airway obstruction, and airway exchange problems. The lungs do not increase in size as the patient becomes heavier. Therefore, the patient may have resting hypoxia and hypercapnia. This is because pressure from the abdominal and the chest walls restrict the lung expansion, which results in poor ventilation. Obese patients also have a high incidence of pulmonary hypertension, basically resulting in heart failure. So these are different things that you look at. Now, we put patients in various surgical positions. Each patient is unique and has specific considerations such as age, joint mobility, and disease. Because of the high risk of serious and permanent injury, the surgical team must be guided and directed in the positioning process. The anesthesia care provider, the surgeon, and the circulator draw this direction from their knowledge of the patient's status. So what do we have to do? Well, we need to know the common positions and the surgeries. That means that we need to kind of think about the position, preferably before the patient comes in. We proactively trying to prevent accident and injury, not only for the patient, but for ourselves as well. And we're going to be questioning potential risks. We're going to remain alert. We've got to stay focused, and we're going to communicate with each other. Communication is the key. Now, we have some general operating room table features. The very first picture that you see are just some pads. Okay, these are the pads that are on the operating room table. Our beds are electronic, so we have remote controls, and yes, they look like the normal remote that you use for your TV, but they are slightly different because they are for the patient bed. They help the patient's bed go up, down, lateral. We have head and foot boards that can come out, and that's where you see like just a detachment, kidney rests, and we have cutouts that helps us for certain positions as well. There are other components that you'll definitely get your hands on once you get into the operating room and even in the lab, from your removable head section to the kidney elevator that we mentioned. There's the hand control that you kind of saw. There's a hydraulic lift, the base, floor locks, locking swivel casters and side rails so that the patient is locked inside. And the video that you're going to watch kind of breaks it all down as well. Other attachments: arm boards, shoulder braces, stirrups, headrests, padded frames, and footboards. I want you to think about all of the surgical procedures that can be done. Well, we have to have certain positions for those. Not every patient is going to be in supine or prone position, which means that we're going to be wanting to prevent patient injury. Nerve and blood vessels. These are things we're looking at. Compression injury, shear injury, pressure, skeletal, respiratory compromise, and we definitely do not want our patients to fall, right? That's a very bad day. That means that positioning is not a regimented routine. Each patient is unique and has specific considerations. That means that we need to know, as the slide says, knowledge of anatomy and physiology. We have to plan. We have to think about the case that we're going to do and plan accordingly, which means that every member on the team has to play their part. So we look at safety precautions for each of positions, okay? The positions: supine, Trendelenburg, reverse Trendelenburg, lithotomy, Fowler, modified Fowler, lateral decubitus, prone, Krask, also known as jackknife, which I have seen in this question on the CST exam. We also have our spinal table and our orthopedic table. We have this video that we're going to watch that breaks down these patient positioning and talks about everything that was mentioned in our session. So let's watch it.
Hey everybody, welcome back to another Surgical Tech Tips. We are back in the OR, finally, and I wanted to do a video on this bad boy right here, our OR table. I haven't really gotten to talk about the OR table, and I thought it would be good to go through some positioning and kind of take you through, the controller that the anesthesiologist uses as we position a patient, and all the kind of different options and safety aspects that you can see with this OR table. Here we go. All right, so to start things off, we're going to be going over different positions on this table. And first and foremost, most common position you're going to see in the operating room as far as surgical procedures go is supine. The supine position is the body's most common way to lie. You're just lying on your back. Man, this is actually kind of comfortable. I've never actually sat on the OR table before. This is actually pretty comfortable. Arms can be out or arms can be tucked. If your arms are out, they say that you should not keep the arms out more than a 90-degree angle. So instead of a 90-degree angle, you want it just a little bit lower. If you go a little bit higher and you have an hour, 2-hour case, after that patient leaves the OR, they could have a brachial plexus injury from overextension of the arms up. So they say you should keep it at below a 90-degree angle in this supine position if you are keeping the arms out. Working on the lower half of the body. If you're working in the upper half of the body, in the abdomen or in the chest, majority of the time we will tuck the arms. We have a sheet usually over this bed. Just for this exercise, I just wanted you to be able to see, the pads. But we have a sheet under this bed, and there's a sheet under the patient, and we can actually tuck the arms next to the patient during a surgical procedure. We pad them, pad the ulnar nerve over the elbow, and basically pad, this whole arm as we tuck it to their sides. So as far as types of procedures that you might see supine, I said before it's going to be the most common position you'll see in the OR. Pretty much anything abdominal-wise is going to be supine. Anything femoral, anything in the legs, so that could be, fractures. It could be vascular cases in the leg, open hearts going through the sternum, chest. That's supine. There's a lot of cases that are supine. Some of the ortho cases and spine cases can be supine as well, but we have different beds, fracture tables and Mayfield tables and stuff like that they might utilize for those types of procedures. They just have different attachments, things like that. We can go over that in another video. But majority of those cases are all going to be lying flat on the back, supine. So one of the first modifications of the supine position is Trendelenburg. Sometimes doctors like to call it head downenberg because you are placing the patient's head down. You'll see this a lot of the times in pelvic surgery when they really need to displace all the organs in the abdomen and kind of displace them up toward the head. So gravity works for us here. We're basically pulling the head of the patient down, putting the feet up, and it's displacing all those organs, cephalad, up toward the head, and that's going to give us more room to work in the pelvis. And fun fact, actually, if you are in a case and your patient is getting really Brady and their heart pressure is going down, one of the first and most effective things that you can do to bring that pressure back up is Trendelenburg. Because what you're doing is you're taking all that blood and venous drainage and sending it right toward the heart to bring the pressure of the heart back up. Fun fact. Now, the opposite of Trendelenburg is, somebody guess it, you guessed it, reverse Trendelenburg. So that's going to be head-uppenberg. Sometimes they like to call it. And in this type of case, obviously you're displacing the organs. Caudad, you're bringing them down toward the feet. If you're working somewhere in the upper abdomen, maybe liver, maybe you're doing a gallbladder or something like that, you want a little reverse T, you'll bring the head up a little bit and kind of displace those lower abdominal organs down toward the feet to give yourself a little bit more room to work. And just like the fun fact with Trendelenburg, with bringing the pressure up, sometimes you have to watch the pressure. If you give a little bit too much reverse T, you're taking away too much blood from the heart, and you can get a little Brady. This next position is Fowler's position, sometimes they call it like a beach chair position. A lot of the cases that you'll see in this type of position are going to be possibly some breast surgery, breast aug, or any type of breast surgery where you need to see like the natural lie of what the breast looks like. You might see it in like shoulder scopes, arthroscopies, things like that, and even possibly any certain types of head cases as well. Now you're probably wondering why there is a big hole down here between the pads on this bed. And this hole is here and in place basically for this next position, lithotomy. We have two different types of leg devices to hold the legs up for the lithotomy position. I'm going to show you the first one. This is the candy cane. But first and foremost, after we get the patient on the bed, we put them to sleep. We will put their legs up both at the same time up in these either stirrups or candy canes, and then we will remove this portion of the bed. These little nubbins can go down by just hitting the leg down button. And now the doctor has perfect access to the patient's pelvis. A lot of the times I know you ladies know this position well because, when you go to get your pap smears and stuff like that, you have to kind of be in this lithotomy position at your doctor's office. But for the men out there that do not know, oh, I can't believe I'm doing this. Let me take this off. You're basically up, open, you have access to the anus, to the pelvis. Obviously for men and women, we have different parts, but the doctors will have access to both. So OBGYNs, you'll see a lot of those types of procedures, any type of DNCs for general surgery. We can do like anal fistulas, stuff like that through this lithotomy position. Urology, cystoscopies, you'll see a lot of cystos all in lithotomy position. But yeah, that's about it. Oh, hold on, let me show you the different device here. This is the Allen stirrup for the lithotomy position. The other one was the candy cane. It's basically doctor preference at this point between the two of them. Bigger cases and cases where you need to maneuver the leg a little bit more, this Allen stirrup works great because of that reason. The candy cane, you pretty much put the legs up and that's where they're going to stay for the remainder of the case. But these Allen stirrups, they have a lot of padding in them. I think they're a little bit more comfortable, and there's a lot more mobility that goes along with these. This next position is prone position. Prone is basically stomach down. I don't know if a lot of you sleep on your stomach. I'm a stomach sleeper, stomach inside. So I'm comfortable sleeping on my stomach, but a lot of people aren't. And this position is obviously utilized so we can work on the back of the patient. So it could be types of, I want to say spine procedures, but I know majority of the time spine procedures are done on a Mayfield bed. I'll show you a picture of that bed here. But it could be, for general, maybe some pilonidal cysts down near the anus. Could be some head and neck things, on the back of the head or on the back of the neck. Again, like maybe some lipomas back there or anything like that. So, prone position. There you go. And similar to supine position, you can have, the arms tucked in close to the patient, or in this case, have the arm boards up in a comfortable position and just keep the arms attached to the arm board as they're up. Now this position here is, they call this like the Kransky position or like the jackknife. Again, this is a modification of the prone position, and again, you know, could be used for like the pilonidal cysts. A lot of the times they'll do a slight jackknife. It might not be anywhere as severe as this. All right, for the last position I want to talk to you guys about, it's going to be the lateral position. Lateral position is used anytime you're going to access the thoracic space. Any type of lung surgery that you're going to do, you're going to be using lateral position. There's a couple different types of positioning devices. Sometimes doctors like to use a beanbag, which is an interesting device. Majority of the doctors I work with don't utilize a beanbag though. They'll just tape a patient. Tape a patient to the bed, but essentially the lateral position is exactly what it sounds like. Patient is lateral. Their lower leg is bent. Usually have a couple pillows in between the legs, and the top leg is straight. Your arms are out. Your arms will be out on one side, and you'll have a couple more pillows right here, just to try and keep a nice, comfortable space. That is pretty much it for the different types of positions on this table. Here's a little video of, you know, some patient padding devices that we utilize. I kind of touched on them when I was talking about the positions, but mainly we're trying to pad bony prominences that might be injured, as well as nerves that might be injured, like the ulnar nerve around the elbow. So we just have to ensure that we pad, you know, all those types of places. And, you know, the padding on these OR tables is super thick, super squishy. It's like this thick gel memory foam. It's like 5 or 6 inches thick. It's actually very comfortable. That was my first time ever even getting on this table, and it's actually very, very comfortable. Yeah, but we try and pad all those types of bony prominences and nerves to, you know, keep anything from getting damaged that, you know, we don't want damaged, obviously. Thank you guys for watching this video. I hope you thought it was a little educational. I know we get to see these different positions and pictures of those positions in books, but it's kind of interesting to see it on an actual table itself. That's about it, guys. Thanks for watching. Thanks for sharing and liking the videos, and I'll see you guys in the next one. Bye.
All right. With that, if you have any questions or concerns, please reach out. I just thought that was a great way to kind of bring this chapter all together. And I look forward to seeing everyone who can attend the live session.